Today we have Matthew Charnetski. He is the Director of Simulation-Based Education and Research and Interprofessional Continuing Education at Dartmouth.
Wow.
At Dartmouth Medical Center. And he is going to give us a talk on debriefing today. So Matt, thank you very much for coming down.
Thanks for having me. It's my first time actually coming to all this, so it's kind of rad. And I feel like you and I have been on WebExes together. Okay, that explains it. I was like, I know that human being from somewhere. She is taller than I thought, which is, I don't know why I have this bias towards thinking everybody is short. I have another person who works on my team. She's like 6'8", and I didn't know it. I hired her and she worked for me for a year. And then one day I was at the Sim Center and I came around the corner and I ran into her belly button and I was just like, oh, yeah, got it. So anyway, my name is Matt Charnetski. You can call me Matt. You don't have to call me Matthew. Also, anything that starts with an M and is a single syllable, I'll probably answer to that as well. My presentation style is pretty informal. If you have questions, ask them, raise your hand. If I'm making you upset, throw things at me or curse or whatever you need to do, that's fine as well. If you start to get sleepy, because we've got 2 hours together today, and debriefing can hit some lulls here and there, get up, move around, whatever you need to do. If you have to go to the bathroom, that's fine. If you hate what I'm saying, that's cool too. Feel free to walk out. We can talk about it later. We can never talk again. Whatever you prefer, I'm fine with it. I do have a couple of disclosures because we're talking about debriefing. I just want to let you know that I do work for a group called the Debriefing Academy. We teach classes on this. They're typically a 6-week-long class that gets into a lot of the practice of it and actual simulation of debriefing, so we can actually use the techniques that we try and get people to learn healthcare. We try and use it to teach debriefing. I also teach for MGH IHP and their simulation operations program. So as I plug master's programs and talk to you about simulation and things like that, we might dig into that a little bit, so I don't want you to be tricked. And then I also do accreditation site reviews for the Society for Simulation in Healthcare. So I evaluate simulation programs to make sure that they're kind of holding up these standards. We'll talk about those in a little bit as well. So I just want to make sure all that stuff is up front. Now, why do you care what I have to say? Maybe you do, maybe you don't. I hope you do. I think debriefing is one of the most powerful things that we can do, and it really provides us an opportunity, not just in our education, not just in simulation, not just in what we call bedside learning or after-action debriefing and that sort of thing, but kind of in everything. I found that I often use debriefing techniques when I'm having difficult conversations with my partner or when I'm navigating anything like that. Once she realizes I'm using debriefing techniques, it goes completely off the rails and she gets really mad at me. But up until that point, I found them to be very successful. Now, for you all as emergency services folks, how many of you are EMS? Anybody fire? Fire and EMS? Okay, right on. I started my EMS career as a wilderness first responder and ultimately wilderness EMT working in Antarctica. So I was part of the Joint Antarctic Search and Rescue Team. It was my first job out of college. It was rad. It was the best way I could have spent my 20s. That said, I didn't know I was doing simulation and I didn't know that I was doing debriefing because I'm sure like many of you, we just called it scenario-based training or that sort of thing, right? Turns out there's this whole field built on that. And we spent a bunch of time figuring out how to do things, specifically debriefing. As my career progressed, I moved back to the United States. I wanted to be a paramedic, because who doesn't want to be a paramedic, right? Everyone's like, no, none of us do. We're not so interested anymore. I wanted to be a paramedic. I was working as an EMT basic. When you go from climbing mountains and flying around in helicopters and living in Antarctica and traveling the world and whatnot, and then you move back to your hometown of 8,000 people in central Iowa to be an EMT basic, you start to evaluate what you want to do. I couldn't afford paramedic school, so I'm a nerd as well. There's a lot of layers to all this. I'm a nerd as well, so I got into electronic medical records implementation, which is much more boring than anything else. But it paid the bills and it paid for me to go to paramedic school, which was sweet. And then as I worked 5 years full-time as a paramedic. And as I got through those 5 years, I started thinking, all right, what's gonna be the next thing? I started looking at master's degrees in healthcare administration, public administration, stuff like that. But I was always drawn towards education. So I started thinking about that as well. And then they posted this job at an osteopathic medical school near where I was a paramedic. And they were looking for somebody for a simulation specialist. And I was like, I don't even know what that means. Like, what are those words? But I started looking at the job description. I thought, oh, this is cool. It's super nerdy. You get to play with technology. It's in education. These people, bullet point by bullet point, were looking for Matt Charnetski, which made me super excited. Like, who doesn't like to be the prettiest girl in the room, right? So I was really stoked for that. So I applied. Apparently they had already chosen the 2 people they were going to hire, but they saw my resume, which was literally like, we want 5 years of IT experience with healthcare IT being preferred, and 5 years of patient care experience with paramedics being preferred. And I thought, there's like 4 of us in the Midwest. We'll at least be friends. They saw my resume and they thought I was lying, so they thought it would be fun to invite me in to catch me. So I went in for this interview, and what was supposed to be a 30-minute interview, 5.5 hours later, I was like, I want to do this for the rest of my life. And I'll tell you what, the weirdest part, the thing that sucked me in, not specifically or literally, was watching a second-year medical student do his first simulated digital rectal exam. Now, that is not something that is in my scope of practice. I don't imagine it's any of your scope of practice. But sitting behind the one-way glass in the simulation center and watching this kid go up and they have the conversation with the mannequin, we're gonna do this thing, we need to check you for this, and this is what we're gonna do, and watch him really awkwardly struggle his way through this. And then he walks over to the task trainer, right? Because the mannequin does not, it turns out, have all of the appropriate orifices to do this exam. Walks over to the mirror, the one-way glass that I'm standing on the other side of with all the staff and everything. And he stands at this mirror, and there's a plastic butt, and I'm like, this job is the weirdest thing I've ever seen in my life. Like, this is so cool. And he proceeds to put his glove on. Fabulous, great first step. Then he takes out the lube, and he proceeds to just very gently put it deliberately on every, and I thought, what is happening? We are this far apart. We are making eye contact. He doesn't know it because he's on the other side of a mirror. But we're doing this thing, and I thought, oh boy, now Siri's looking it up online. Nobody should feel good about that. And I thought, I want to understand what's going on. He looked creepy. He was, the whole time, he's like, So they let me sit in on the debriefing. Now, at this point, I had never experienced a true debriefing. So they're going through all the steps, they're asking the questions, they're doing things, and they said, Matt, would you like to ask any questions? I said, actually, I'm really curious. What were you thinking about when you were doing that? Because that was really intense. And like, I think a patient or a family member or anybody else in the room is going to be a little put off by this. But 2, like, you were in the zone. Like, you were focused on this task. And it doesn't seem like a task, I guess, that I would have anticipated required that level of focus. What's up? And he says, well, there's 2 things that we've learned about digital rectal exams. And I said, only 2, but fine. He looks at the faculty member, and the faculty member says, number 1, there's only 2 reasons you don't do a digital rectal exam. And I thought, I feel like there's a lot more reasons than that, but I'm learning, go ahead. He says, if you don't have a finger, or they don't have a rectum. And I thought, I'm definitely not going to see this guy for my allergies. Like, let's start there. I'm not interested. And I said, okay, well, that's good. I guess that still doesn't explain. He said, the other thing we learned is that you should treat other people as you want to be treated. And what I thought was, I would want to make sure that finger was completely lubricated before we went through this thing. And I thought, oh, that makes sense. I would not have guessed that. I would have not thought about it. I wouldn't have even explored that, right? So this is my first experience with a deliberate debriefing. Since then, I've spent a lot of time learning about this, because the other thing we've learned about debriefing is there's a lot of ways to do it wrong, and there's a lot of ways to injure that relationship with the learner and to affect their career as they move forward in positive and negative ways. So, what I've done since is I've gotten my master's in medical simulation. I'm working on a PhD in health professions education. I've been teaching with these different groups doing debriefing stuff, and I've been practicing my craft because it takes a lot of practice and a lot of work. So what I'd like to do today, if you guys are up for it, is share with you a lot of the things we've learned and give you some of the basic structures and information that we've got surrounding debriefing, whether you're using it in training, whether you're using it after actual situations, or whether you're just using it for fun whenever you get the chance. Sound good? Yeah. Got a thumbs up, a couple yeses, some nods. 2 people asleep. Just kidding, nobody's asleep yet. So, what do you guys think of when you think of debriefing? Learning.
Difficult conversations.
Difficult conversations. Improving.
development.
Development.
Guidance.
Guiding a discussion, sure. Okay, fair. All very reasonable answers. And do any of you actively engage in debriefing right now? After an event, after sim? Sure, after education? Do you guys use a method? Do you just kind of do what you've done or what you've been trained loosely?
I went down to the Harvard Medical School.
Yeah.
Their design and debriefing class, so I used their like
Sure. Debriefing with good judgment? Yep. We'll talk about that in a minute for sure. Anybody else? There's a million different methods. 950,000 of them are good. Some of them are a little weird. What I want to take you through is the method I use and the one I advocate for, only because I think it's simple. I think it touches on a lot of things that we want to make sure we cover. And it's a pretty easy way to get started and then to build on from there. So from my perspective, the purpose of a debriefing is you observed some sort of performance, whether it was in real life, whether it was in education, whatever it was. And there was a difference in what you observed from what you expected. Now, that might have been they totally messed it up. They just did everything the wrong way. It might be that they blew you out of the water. You were like, holy cow, I did not expect that to go as well as it did, and I want to understand why. We want to correct those negative gaps. We want to close those gaps. And then we want to bring everybody forward and make sure that when they did that really great thing, they did it for the right reasons. Have you guys heard the phrase, doing all the right things for all the wrong reasons? Right? Someone comes in, they misinterpret a situation. Their performance was stellar, but it turns out they were doing it for really dumb reasons, right? We want to figure all those things out, and we want to help everybody improve. So our goal is just to move the needle. It's not that we need them to do this or this, right? There's some assessment stuff in that. That's different than debriefing. What we want to do is we want to move that needle. So we're analyzing that gap, and we want to get to the root cause, right? So having that conversation with that second-year medical student and understanding why he did the things that he did, all of a sudden I was like, oh, maybe that's not so weird. Maybe you need to police your face a little bit. Maybe you need to think about like having the creepy look on your face the whole time. But beyond that, like everything you did made good sense. We want to carry that forward. When you are facilitating a debriefing, there's a bunch of different things that you're trying to do and you're trying to juggle. So sometimes you're a guide, right? A guide on the side, I think is the phrase that they often use. So you're trying to develop those relationships, you're trying to help this person grow and develop, building a structure that they can work on. Sometimes you're a facilitator, so you're trying to understand the perspective the learner's coming from. You're trying to help them help themselves, those kinds of things. Sometimes you're a mediator, right? Sometimes you're dealing with a team that's really struggling and you need to kind of navigate that, help them understand their team dynamics or figure out how they can communicate better, how they can work together better as a group. Whether it's a team of 2 or a team of 10, doesn't really matter. And then teaching goals, right? There are times when people show up and they don't know the stuff they're supposed to know. So we're trying to balance all of these goals as we're facilitating these debriefings. And there's different pockets that we're going to stretch into in our debriefing practice as we go. So there's some things that we want to keep in mind. One is the basic assumption. Harvard, you've heard of the basic assumption? Do you know it off the top of your head? I mean, it's written right up here. It's the gist, right? The gist. Essentially, the idea here is that you want to think well of the people you work with. You want to think well of your learners. So, coming into it, you want to believe that they're smart, that they approved or applied some logic of some sort, whether you agreed with it or not, they applied some logic. They're well-trained, they're well-intentioned, they want to do right by their patients or by the community, and they want to get better. How many of you have run into people that you're not totally sure all those things are true about? It's okay, you can raise your hands. The camera's on me, not on you guys, so you won't get ratted out. Absolutely, there are times. But as facilitators, coming into this is going to help you, keeping this in the back of your mind the whole time, it's going to help you avoid getting into a spot where you create more difficult relationships with people than you need to. You guys heard of the phrase borrowing trouble? Start worrying about something that actually isn't yours to worry about. This is borrowing trouble. You start getting a little judgy, a little pushy, you're creating something that you were trying to avoid all along. We don't want to borrow any trouble. People are logical, right? Even when you see somebody do something absolutely stupid, if you dig deep enough, you will find a reason they did the thing that they did. It may be a terrible reason. It may absolutely be something you disagree with on every level that you've got, but they apply some logic to get where they go. We won't get into it today, but if any of you ever want to geek out on decision-making paradigms, it's one of my favorite things. They get super weird, but we know the process that people go through in different instances to make decisions. We know they're applying this logic, even if they don't know they are. So keeping that in the back of our mind, we know that you go in, you do something completely unexpected from what I was hoping you would do in this scenario. There's a reason you did that. Our job is to figure out what made you make that decision rather than this decision. Or maybe you did a fabulous job, blew the doors off of it. What made you go that route versus the route I really expected for the level of learner and all those kinds of things? How many of you have been told not to be judgmental? I was going to say, come on, we all went to kindergarten, right? Right? So the reality is when people come to us for education, they are there to be judged, right? They came to us because they want to get better at what they do. They are trusting our expert advice and opinion, our teaching, our mentorship, our facilitation to make them better. They are there to be judged, and that's where we get into debriefing with good judgment, which is this idea that we can provide judgment, we can provide education, we can provide observations and mentorship without being a judgmental jerk. And we'll walk through some of the pathways to get into that as well today. How many have had the concept of psychological safety beaten into you? Just a couple of you? So psychological safety is something that we talk a lot about in healthcare. And it's getting kind of a bad rap, right? This falls under that umbrella of everybody gets a trophy, nobody fails, all this kind of stuff. That is not what psychological safety is, right? Psychological safety is the idea that in education, we have the opportunity, particularly simulation education, we have the opportunity to fail without real consequence. That under all of these other things, we are here to move that needle to improve. So come in, stretch your limits, come do what you think you should do. If it's not right, I'm not going to yell at you, I'm not going to talk down to you, and I'm not going to treat you differently. We're going to have a conversation, I'm going to help you move that needle. That's the end of psychological safety. Real and hard consequences. It doesn't mean it's not challenging, doesn't mean it's not hard, it's not uncomfortable. It's going to be all of those things, but it's not going to be permanent and it's not going to affect our relationship outside of this training scenario. And then engagement and suspension of disbelief. So when we look at sim, how many of you guys engage in simulation education? Just a few of you. So here's the secret. We all do it most of the time in emergency services, we just don't call it that. So how many times have you said, all right, this person's laying down and they've fallen off this ladder, so we're going to practice what we have to do to get them ready, right? How many of you gone out to the burn house to do all that stuff, right? That's all simulation, right? Burn houses are cool. I got to go on my first one. I was at a very strange resiliency class a couple of months ago. It was rad. It was really difficult. I really respect people who do that stuff, but really interesting. That's all simulation. It's any opportunity that we have to do something in an environment that has some controls on it. Even if it's just sitting here and we talk through, all right, you were at this fire, this is what you did, let's talk through what we're going to do next. That's a form of simulation. So when people start participating in simulation, one of the things we get a lot is their response is to disengage. So they say things like, well, with a real patient I would, or in a real fire I would. Trying to encourage people to engage with that. The more you treat it as though it is real, it is how you would behave in a real situation, the more valuable that experience is going to be. We do that in a lot of ways. We do that in Fidelity by creating it, making it as real as possible. We also do that by asking people to engage in suspension of disbelief, or the fiction contract is what we call it sometimes. And the idea is we know it's not going to be perfect, right? Our mannequins, any of you guys worked with mannequins in any of your EMS training? Yeah, they're super creepy, right? They aren't quite human, which is better. There's a whole uncanny valley thing we'll get into over, drinks or something at some point. But they're not super real, but we ask you engage with it like it's a real patient. I've never had a patient where I can walk up and I'm like, here, I'm gonna start your IV and I'm gonna screw it onto this thing, right? Like, that's not real. But through suspension of disbelief, I know it's not gonna be real. I'm gonna push past that and still treat this like a real scenario. That's gonna help this become more valuable. So keeping all of that stuff kind of in the background as you're building up these scenarios, as you're working with people in their training of whatever sort, it's gonna help you then facilitate these debriefings. So when we look at all these goals that you're trying to balance, at the center of that, the only way these things work is by creating that psychologically safe, engaging environment. So we're not being judgmental, but we are judging. We're encouraging them to engage with this, treat it as though it is a real scenario, treat it as though it's a real patient, a real fire, a real whatever. We're working with them to help them realize that they are good at what they do. We just want to keep helping them be better. We want to create lifelong learners. We want to build all of these skills so that they're able to keep moving forward and have a long, happy career doing what they love. So we keep all this stuff in mind. So when we're trying to create psychological safety, and I'm laying this as a groundwork because I do think this is a really important thing and something that I did not experience in my early EMS career. When I started as an EMT basic, I've never been called dumbass more in my life. Now, I don't think I'm a dumbass. I have my moments, don't get me wrong. But it would be things that I just didn't know, right? Like stuff that I had not been trained to do, I was learning. I was a brand new EMT. But if I didn't do it exactly right, dumbass, why are you doing this? Dumbass, why are you doing that? Because I didn't know any different. When we work to create these psychologically safe learning environments, when we treat each other with respect, when we are non-judgmental, but we are providing providing feedback to help people grow in a positive direction, people stay in the career longer, people are happier doing what they're doing, people provide better patient care, they work together better in teams, they have less burnout. Everything that we want to do, everything we talk about wanting for our people comes forward. So when we're trying to create psychologically safe environments, there's the verbal stuff, right? Like, it feels nice when people are like, hey, I appreciate you being here today. Like, that was really good. I appreciate what you did there. That was really great work on that call. Like, what you did, like, the way you talked to that patient, that was cool. It's really well done. Like, turns out you're good at your job. I like that about you. Normalization. Hey, you know what? Backing up an ambulance before there were backup cameras on all of them, that wasn't super easy all the time. Like, we've all been through it. It's something you grow on and will work on, normalizing it. All these kinds of things are things you can do verbally. And then 80% of our conversation or of our communication is nonverbal, right? So having that open body language, leaning in and listening, maintaining appropriate eye contact. Have any of you worked with somebody who is really bad at eye contact? Like, they know they're supposed to do it, but they don't understand how it works? A little bit. Maybe I just hang out with a lot more like people further down the spectrum. I've worked with a lot of people that are just like, so I could use your help on this thing. But I'm not really sure what I did wrong. So, right, it's uncomfortable. Yeah, right, I believe it. I'm sorry, I apologize. And distributing that eye contact. So they've been doing a bunch of research recently in what the appropriate amount of eye contact is. So they've been using eye tracking on people in debriefings and in difficult conversations to see what the right amount is. And it turns out there's a pretty standardized right amount. Now, I don't know how we're gonna like sit there with our stopwatches and be like, oh, okay, all right, I crossed the threshold, it's time to stop looking at this person for a little while. But managing that stuff. Levels, right? When we talk about patient care, you want to get on the level with the patient. It's the same thing with learners. And then state of mind. When we're approaching these things, when we're approaching a facilitation of a debriefing, whether it's a real event or a simulation thing or whatever, start with curiosity. They applied some logic. There was a reason they did the thing they did. It wasn't what I expected, or maybe I didn't even particularly like it. But if you start from being curious, you're gonna be in a better spot for that conversation already. All right? Now, some people take it to a whole different level where they will literally say, so I'm curious. They start everything with that. There's a lady in sim that everyone knows. If you talk to somebody who's been in sim long enough and you say, I'm curious, they'll be like, oh yeah, you trained with this lady down at CMS who is curious about everything. She genuinely is, but I mentioned we've been doing a lot of research in debriefing, and a lot of this comes out of psychology. It's a lot of stuff where they're really digging into how people learn well, how people form strong relationships in mentor relationships and teaching relationships and that kind of thing. And in SIM, we've put out a lot of recommendations on this, and it's constantly growing, it's constantly changing. The last 3 years, as you can imagine, we've had this whole new field of virtual simulation and virtual education that we've had to figure out what that means for debriefing, which has been a mess. Super interesting, but a mess. So to that end, if you are engaging in simulation education or in debriefing in general, interprofessional education, all these things, there's a few organizations that have put together recommendations for this. The first is the International Nursing Association for Clinical Simulation and Learning. And Axel, it's way easier. I've been practicing saying that out loud for days now. And Axel created a whole series of what they called the nursing standards for simulation best practice. And they created them about 15 years ago. And they were really well researched, well designed and all this. The problem was the only people on the teams were nurses. They were looking at it solely from a nursing perspective, and they were only looking at nursing simulation. Now, there's some fundamental things that hold true across simulation, but there's a lot of things that different professions disagree on or have different approaches to. So in the last iteration, starting about 4 years ago, we actually totally revamped the system and started putting together interprofessional teams to bring this together. So they became the healthcare simulation standards of best practice. There's a Dropbox link that I think Max is going to send around to all of you guys that are attending. It has all the standards in there. It also has the infographics that they put together on those, so the current versions of all that stuff. But in these standards, what they did was they put together groups of people who then would do extensive literature reviews. They came with their own experience and expertise, and they put together recommendations on what different things need to include within simulation. Debriefing was one of the first standards that came out because it's something that we have so much opportunity with, but also so much opportunity to do poorly. So the debriefing standard is one thing that's out there. There's also a pre-briefing standard, which a lot of people don't like that word. Why do you have a pre-brief if you have a brief? Is a brief just a brief? Is a whatever? Doesn't really matter. The idea being that you are preparing your learners for what they are headed into. You are then preparing them to head into the debriefing. Those things are the pre-briefing, and we'll talk about that a little bit too. The Society for Simulation in Healthcare also put together a bunch of recommendations. And a lot of their stuff on their accreditation and their certification. So accreditation is for simulation programs. Certification is for individuals. They have a certified healthcare simulation operations specialist and a certified healthcare simulation educator. Both of those things come with a lot of recommendations on where you should be looking for knowledge and a basic understanding of debriefing, of how we should carry it out, what should be included, and that sort of thing. The Center for Medical Simulation, which is sort of the root of a lot of modern debriefing techniques. They also have a tool that I've included in that Dropbox as well that is meant for evaluating debriefings. But the nice thing about it is it pretty explicitly spells out what you should be trying to do in your debriefings in terms of psychological safety, in terms of approaching the learners, in terms of how you include content and that kind of thing. And then there's a book out, Defining Excellence in Simulation Programs. The second edition just came out. That is geared more towards those accreditation standards, but it also has a lot of information about best practices in debriefing and then connects you to a lot of other resources. There's a lot of books out there now. The folks from the Debriefing Academy, they put together a book on debriefing a number of years ago as well. I don't recall the title, but there's a lot of things out there that can give you more and more resources. We'll get through the basic structure of things today. If you guys want to practice more in the future, or if you just want help, let us know. We're happy to send people down and we can hang out with you while you're doing debriefing, and we can talk through different ways to make it better or whatever you need. We have a couple of other classes that we offer for free at Dartmouth Health as well. So I'm not trying to peddle you guys anything that you have to come pay for. But just reach out to me and we'll be able to connect you. We just developed the initial module, which will cover a lot of the same stuff today. The secondary modules are things that we're developing. It's all synchronous and online. Yes, sir?
Can you do that eye contact thing again?
I promise. Yeah, it'll be extra weird through the WebEx too, because then I'm just staring at a camera the whole time, which requires you to do the same if we're gonna have the awkward interaction. If not, just look away from the camera. It's the beauty of remote work. Here are the infographics for pre-briefing and for debriefing. So you can see there's just a few things. It's not a ton of stuff, but understanding exactly what it is we expect for people to carry out a positive pre-briefing and a high quality debriefing. Using these standards, we've then distilled it further down to say, these are the things we want to make sure we include. So there's some stuff in there that just kind of makes sense, right? Like you want your simulationist to be, some people call them simulationista, which feels like somebody who is from like Central or Southern America and they're overthrowing the simulation government or something like that. I don't know. I'm fine with that on some level, but the simulationist, you want them to know the subject matter and that kind of thing. There's some wiggle room in that. We have some techniques called co-debriefing, where we might have someone who is an expert debriefer, but not a subject matter expert, and they bring a subject matter expert along. There's some advantage to that, some disadvantages to that. That is a whole other animal. But you can see that there's some pretty straightforward pieces to that puzzle. As I mentioned, the Centers for Medical Simulation, we can't talk about debriefing without talking about them. We certainly can't talk about debriefing in New England without talking about them. They do a lot of really great work. They've developed a lot of really interesting things. The DASH tool is one of them. The concept of debriefing with good judgment is kind of the other main one. Now, debriefing with good judgment, there's many layers to it. I have not taken the instructor course, so most of what I know about CMS and debriefing with good judgment is secondhand and from the papers they've published. Fundamentally and functionally, though, it is we are here to judge people, but we will be non-judgmental in the way that we do. And this method of debriefing called advocacy and inquiry. And we'll talk about building those. Those questions are a little bit more difficult. It is a little bit more advanced debriefing technique, but it's really valuable, particularly with people who have a close relationship between their personal and professional identity. Have you guys ever tried to talk to somebody where something didn't go the way you thought it would, and they just get super defensive and really mad all of a sudden? I was going to say, if none of you have, I'm jealous, super jealous. So in healthcare, we have the same thing, right? People their personal and professional identities are really closely tied. So the moment you say, hey, I was kind of expecting this, and this is what I saw, it starts to feel to them like a personal attack, and things just go off the rails from there. This is a technique to kind of help dodge that a little bit. And then some other models. So we had talked about debriefing with good judgment. Nobody else had anything else that they specifically remembered the name of, is that right? Or they didn't want to share because they were afraid I'd pick on them or make eye contact with them for an uncomfortable period of time. So gather, analyze, summarize, that's what the AHA used to use. So how many of you are AHA instructors? A few of you? So that was not originally, 20 years ago, they didn't really have a debriefing. They had a script that you walked through and you just kind of like give them what we call directive feedback. So you'd be like, oh, you need to push harder on the chest, or you need to give more recoil, or whatever it was. Then we moved to gather, analyze, summarize. So talk about the performance a little bit, and then we'll dig in a little bit, and then we'll summarize the thing. It's a great debriefing method, works super well. It's a little complicated, and it left a little bit too much to chance for the way the AHA likes to run their stuff. So now they've switched to plus delta is the method they've used, and now I think actually we're even moving into pearls, which is the method we'll talk about today. Debriefing with good judgment, plus delta, which is what went well, what might you do differently next time. After action review, has anybody ever gone through those, or after action report? Particularly if you do anything with the military, it's pretty common in the fire service. Works super well. They're great methods to use. They are not what I would consider to be a modern debriefing technique, only because we've added so much more of this psychological learning engagement element to a lot of the things we do. Doesn't mean you can't do those methods. Just means you have to do a little bit more of the work to bring all of those modern techniques to it. So, just with that overview so far, how's everybody doing? Hanging in there? Got a thumbs up, an enthusiastic thumbs up, if I may say. Any questions about any of that stuff so far? When I first got into SIM, I was a little bit confused because I didn't realize there were all these organizations doing all of this work behind the scenes, because I was coming out of EMS, so I had all of that stuff, which was awesome, that tons of resources and all those things. But like anything else, as we get more specialized, as we start to lean on each other more, there's people who are working on this one little band of the thing. And so that's where the opportunity then is for all of us to come together. I don't know nearly as much about EMS or EMS education as I once did, and even then I probably was pretty middle of the road, but SIM is the thing I've kind of thrown myself into, and there's lots of opportunity for give and take between those things. Same thing with medical education. I haven't worked at a medical school for about 3.5 years. It's a totally different world than even when I was there last. But SIM is the thing that now I'm really up to my eyeballs in. So when we look at a debriefing, there's some things that we want to always see in every debriefing. One is the pre-brief, and we'll talk about kind of the elements of each of these things. So we want to make sure we have a pre-brief. There should be a pre-debrief that reasserts some of the elements from the pre-brief and prepares them for the transition from performance into conversation, but keeps them engaged. So again, talking about that simulation problem where they come out of the sim and then they move into the debrief. I'm not in that sim anymore, so now I'm going to talk about what happened in the scenario or in the simulation, and I'm going to talk about what would happen in real patient care. And what we want to do with that pre-debrief is help that transition to say, you're still in this simulation. We are talking about, we're not going to get into the whole like we all live in a simulation thing. I saw a couple of you light up when I danced around that a little bit, but we want to help them make that transition because we need to stay engaged with the I was performing patient care. I was fighting a fire in that moment. So when we debrief, that becomes more valuable. We want to talk about their reactions, which often this is all about emotions, which can be a little bit of a controversial topic even these days, but there's some really important reasons we do it. And then we want a description. We want them to tell us what they just went through. So this is about making it learner-centered. This is about hearing from them and understanding what they just experienced, not what you intended for them to experience. And then the analysis, which is what we would traditionally call the debriefing. And then the summary of different points and summary of the entire thing. We want to wrap it up, put a bow on it, and send them on their way. So when we look at that in PEARLS, which is promoting excellence and reflective learning in simulation, we love our acronyms. Like I said, I'm trying to become the director of Siberia. Right now, some people call it SBERI, S-B-E-R-I. It's a little rough, but I think we're really close to Siberia, which would be rad. With PEARLS, this provides a really well-formed structure that is not rigid. So it does a few things. One, it hits every element of that DASH tool. So we've all agreed DASH says what the endpoint should look like. PEARLS helps you in a structured way get to all those things. Some people don't like PEARLS though because they feel like it's too rigid, it holds them in. That is not the point of this. Each of these steps we can do in a different way. Each of these steps we may approach and maybe even wave off, right? If I say, all right guys, how'd that feel? How's everybody feeling right now? And you guys say, yeah, I feel pretty good. I'm gonna give you a minute, dig in a little bit. If nobody's really feeling anything in particular, cool, we're gonna move on. I'm not gonna mess around with it. I don't need to drag feelings out of you. There's no reason for it. Same thing with the analysis phase. PEARLS comes with 3 pieces built into it as its structure, but the reality is you can use whatever structure you are comfortable with or that you feel is most appropriate to address the issue that you're on. So it's just a framework. And why? It meets all of those DASH standards. It touches on all of the pieces of the debriefing standard from an Axle. It hits on the blueprints from the CHSOS and the CHSE, those certifications. It's meeting all of these standards that, again, all the research is showing is best practice in debriefing, but it does it in a way where it helps you have a framework to follow. So you're not wandering into this thing blind. It takes a bunch of the load off of you and gives you something to lean on as you go. There's a ton of cognitive aids that go with PEARLS. Those are in that Dropbox as well. And a lot of different ways to implement it and ways to kind of navigate those questions. Why do we want to do this? So we talk about the reactions phase a lot, and PEARLS was one of the first ones to put the reactions phase right up front. How many of you have worked with anybody who has been genuinely burnt out? Or has been deeply affected by any of the calls that they've been on or the accumulation of those calls, right? So we spend a lot of time, and in healthcare we're talking about it a lot more now too, we spend a lot of time talking about how we avoid burnout. Well, the way we avoid burnout is we start working on it way early. And one of those things is to be able to identify and process emotions as we feel them to understand how they affect us in the moment, how they affect us in our patient care or in our teamwork, and how they affect us long term. Sim is a great place to start building that practice now, because it's that psychologically safe environment. It's that space where I can say, you know what, I was absolutely freaked out on that sim we just ran, where we were running on a pediatric code. I am uncomfortable in that moment, and it freaked me out. It made me really uncomfortable. Or it reminded me of X, Y, and Z. And by doing that, we're helping people learn a behavior that we have not spent a lot of time learning, which is processing those emotions. The first time I saw a reactions phase well done, that actually had it's such an obvious impact that it was really powerful, was again at that first medical school that I worked for. And we had a group come in and they were just doing a normal acute coronary syndrome scenario, not a big deal, not a hard scenario to run. And one of the guys on the team, who normally just blew the doors off everything, was just super weird, like just couldn't get his arms wrapped around it, wasn't doing well. He was the team lead and he wasn't directing things well. He knew his stuff, that we knew that wasn't the issue. And so we brought him in afterwards, and we're doing a team debrief, and so we say, how's everybody feeling right now? And most people are like, oh, it's fine, it's whatever. And he says, I was really uncomfortable. And we said, oh, okay, what's going on? Why were you uncomfortable? And he says, well, I've had 3 heart attacks. And I thought, you are in your second year of medical school, and you've had 3 heart attacks already. He says, my dad died of a heart attack, my 2 brothers died of a heart attack. This was the first time that I have seen a patient that was having a heart attack. And it just brought up a lot of stuff, and we were like, oh yeah, that's a thing we should talk about. You want to go into emergency medicine, you're going to see more of these. Let's dig into it a little bit. And we didn't get very far before he said, I don't really want to talk about it. We said, that's totally fine. We don't need to process that here. I'm not equipped to help you process that necessarily. But we've identified a thing that maybe we need to talk about, and maybe we need to find you some additional resources. I had another one where a group of students came in, and I've never seen a group of humans who disliked each other more. Right? So they ran through this scenario and they did all the things right, but the whole time I was like, you guys hate each other. And it was one of those things, like it was like out of Grey's Anatomy, right? Where like 2 of the students had been sleeping together and then they broke up and then they got together with 2 other people. I was like, this is a group of 5 people. There's 200 students at this school. Like, pick anybody else. You guys are together like 3 times a week for the next 2 years. This is a mistake. But in that moment, we could identify that their behaviors were being affected by something. Nobody wanted to talk about all the relationship drama. I didn't want to talk about the relationship drama for sure. But identify that, understand how that affects your performance. And then it helps you come up with mitigation strategies as you move forward. Even if you're going to continue making the same bad choices and dating the people that work in your immediate team all of the time or whatever it happens to be. No judgment there. But if you're going to keep doing that, understanding that then when you are in these situations, you have to find a different way to mitigate those emotions and handle those, because it's going to affect your teamwork, your decision making, and your patient care. We want to explore the fundamental pieces of decision making, right? So we talked about people apply some sort of logic, people move forward with that logic, and they make decisions. The decision making paradigm that I lean on most is called ORID, O-R-I-D, observation, reaction, induction, and decision, I think. So basically, you walk in, you see a thing, you have a response. Even if you think you're cool as a cucumber, there is an emotional response of some sort that happens. Even if that emotional response is, right? But still, it happens. You go through that, then you start inducting things. So you look and you say, all right, this is the information that I have, I'm gathering these things, but you've already put your emotional slant on it. Then you take all that information and then you make a decision. Well, if you saw the wrong thing, that's a different conversation than if you came in the room and you were like, well, here's this, crack addict that I'm just having to deal with again, and whatever. There's no way he's having a heart attack. He's a 22-year-old, whatever. It can't be a heart attack, because you had this initial emotional response to whatever you first saw. Then you start gathering information, right? It's like all of us when we get on the internet when you're really pissed off about something, and you just start looking for the things that jive with what you think should be true. Right? Anybody do that? Please don't tell me it's just me. Right? You go out there and you start trying to justify your argument. We do the same thing when we make decisions. But we need to dig into that then when we're seeing a decision was made that didn't match what we were looking for. And then we can correct that. We can say, oh, you came in and you thought that this person was anxious because they were breathing fast, but they were having difficulty breathing. And if we had asked these questions, this is what we would have found. So yeah, they were anxious, but they were anxious for this reason, not this reason. Or you came in and you were immediately pissed off because this person calls every 3 days and wants you to come pick them up off the floor, and every 3 days you want to take them to the hospital, and every 3 days they say no, and round you go. That's a different conversation. So it helps us as facilitators figure out what we're trying to address to close that gap. As opposed to you come in and you say, oh, you saw that person with no arms, no legs, and no pelvis laying on the floor, and you decided you needed to do CPR, right? Because that's how we train people to do CPR. You decided to do CPR on that person, but they had a pulse the whole time. You gathered the wrong information. Secretly, they just couldn't wiggle because they don't have any arms, legs, or a pelvis to be able to wiggle around to let you know they're alive, right? Whatever it was, we're going to address a different problem. So we're trying to figure out where that gap actually was. So in our pre-briefing, we try and do 4 things. The standard has more things, but 4 really functional things. 1, we assert the basic assumption every single time. Part of that is for you as the facilitator. Part of that is for the team that you're working with, to remind them that this group of people you're working with, even if Billy is always out doing stupid things, wearing his like thong bikini bottom and running around drinking beer and doing crazy things, like, you know, he's an idiot off the job, but on the job, he's good, he's solid, he's part of your team. Reminding ourselves that we are working with a group of people who are fundamentally well-trained, intelligent, good at what they do, and want to be better. Reminding ourselves as facilitators then helps us to know, all right, so you want to be better at your job. Great, I'm here to help you be better at your job. So let's engage in this training and let's do this together, right? It creates that relationship and gets it started on the right foot from the beginning. We want to talk about expectations of performance. In sim, we run into this a lot, where there's a lot of things that we just simulate, right? Whether it's, we don't really care if you know how to drop the medication and give it and all that stuff, so we're just going to have you verbalize medications today. Or we want you to come in and we want you to do every single thing, because this mannequin we're using today, you can actually inject stuff into, you can intubate them, you can put them on a vent, you can do all the things. But we want to set those expectations for what we're thinking. Now, this doesn't mean we're going to give away the scenario, right? We're not going to be like, all right, so today you're going to see somebody who's in a VFib arrest. So you're going to come in, you're going to look at that monitor, you're going to know it's VFib, and then, right? We don't need to give it away. We might still be assessing them, we might still be wanting to observe their performance. But we want to let them know what we expect from them. When you work in sim, you get used to the voice of God, right? So a lot of sim centers have a speaker overhead that you can speak down into the room to let them know things. The problem is that then trains people to find God. So there's a lot of times they'll be like, I haven't seen my x-ray yet, right? Like you wouldn't do that in patient care. We don't want to train you to do that. So expectations of performance. If you haven't seen this thing yet that you know you ordered and we know you ordered, it just means it's not ready yet. It doesn't mean you need to find Jesus and ask, right? Suspension of disbelief, and this becomes a really important thing the deeper you get into sim. It's no different though than practice how you play, any of those kinds of things, where it's just treat this like you would every other real life scenario you're going to be in, because now, and I don't really believe in muscle memory, so we don't need to talk about that a whole lot, but we want you to practice the movements. We want you to do everything that you would do, because at the end of the day, when you are totally stressed out, completely cognitively overloaded, you are going to retreat to your lowest level of training, right? The weakest link is where you land. So if we do this in sim over and over again, and you're training to this level, this is where you're going to fall. But if every time you're kind of walking in like, yeah, okay, here we go, it's another one of these, that's what you're going to fall to when you're completely stressed out. Whether it's stressed out because of the call, or stressed out because everything at home is messed up, or stressed out because your paycheck wasn't right today, or whatever it is. So elevating to that level of training, suspension of disbelief. And then psychological safety. This is a place where we are here to learn. We are going to keep pushing, and we are going to find out about each other. We're going to find out about how we perform, and it's okay to fail here. My family, they're mostly medical malpractice attorneys. That's not true. They are mostly attorneys. My father specifically, though, was a medical malpractice attorney for a long time. So for me, the psychological safety is at the end of the day, nobody dies permanently and nobody gets sued. It's true, right? I mean, that's a thing. So, standards and pre-briefs. Thoughts, questions, concerns?
muscle memory do you not do?
Yeah, so we have reflexes, and we have memories, like we remember how to do a thing, but the idea that our muscles actually remember a thing, I'm not really sold on that. I don't think we've really proven that.
It's just misnamed?
Maybe, yeah. It's a little more than that, and it's beyond reflex, right? We can train people to have faster reflexes and to know that this is a thing I need to do, right? Like martial arts or whatever. But it's still not like, we aren't chickens. If you cut off our head, we don't then continue like running around and doing stuff and all these things, right? To my knowledge. Maybe we do.
Am I to understand correctly that the phrase muscle memory actually was trying to convey that muscles had memory and not that?
Yeah. Because the idea was that then you didn't have to think about it. Now, it may be subconscious, right? You can get me on board with that. But frontal, prefrontal, subconscious is very different than like, my arm just knows what to do, right? It's not, my hand went bad, so I had to cut it off. I don't know if anybody's an Army of Darkness fan in here. No, maybe not. So, once we've gotten through our pre-brief, we've got them ready to go, we've set our expectations of performance, we've done our best to create this psychologically safe learning environment, right? It's not something where you just get to walk in and be like, this is psychologically safe, you are now fine, right? We try and create that environment and foster that. We've got them engaged, they are suspending their disbelief, they're prepared to practice how they play, they do their scenario, and then they come out the other side. Learners will start talking about what they just experienced the moment they finish it, which is awesome. In sim, when we're designing sim centers and doing all that, that means we try and put the debriefing space as close to the sim space as possible because we're talking about seconds mattering, not minutes mattering. So after a scenario, whether it's simulated, whether it's real, whatever experience has just happened, having that conversation shouldn't be something that's delayed. So I know some of the services that I had worked for over the years, we would have critical incident stress debriefings and they would be 6 weeks later or whatever. At that point, I've processed a lot of that stuff, probably in some very unhealthy ways. It's the same thing for learning as it is for real life experiences. We want to try and at least have the initial conversation soon. People's memories are going to fail, their emotions are going to get the better of them, they're going to internalize that stuff, they're going to start eating their feelings, whatever it happens to be, but we want to help process through that stuff immediately. So, our pre-debrief, or setting the scene, is the place where we want to create that transition and we want to get that process started right now. So in a pre-debrief, typically, we're going to reassert the basic assumption. Hey everybody, I appreciate you participating in this thing and coming to do this thing. I appreciate you going on that call, whatever it happens to be. I really think the world of you. You guys are smart, intelligent, you are well educated and trained, you want to be good at what you do. So I just want to take a minute and let's talk a little bit about what we just went through. It can be super quick. I want you to continue being in that scenario we just went through. The simulation we just had, the experience we just had, whatever it is, let's keep our minds in that, and now let's talk about it a little bit. It doesn't take a whole lot, but helping make that transition and set those expectations. We want to communicate with each other respectfully. How many of you have heard the Vegas rules of simulation? What happens here stays here, right? My paramedic instructor always said, you know, what happens here stays here. It's just like Vegas, except for herpes, luggage, and pathological Q waves. No. All right. Anyway.
Quick program.
Yeah, really. It was an interesting time. But something really quick, just helping make that transition. And then we want to get right to reactions. Now, a lot of people, when they start the reactions phase, they'll say, how do you feel that went? That will transition people immediately to the analysis phase. And most people initially will start with the negative. They'll be like, oh, we did terrible because blah, blah. This is about your reactions to the situation. How did that feel? How do you feel? And with a lot of the professions that we work with, so with nursing is super good at this, by and large. Medicine, less so. My experience with paramedics, quite bad. Firefighters, I don't know. I haven't done a lot of debriefing with firefighters. I don't know where they land with this. Could depend on your group, right? sometimes we do have to draw it out of them a little bit and encourage them back to that. So even when I'll say, all right, how's everybody feeling? Oh, I feel like that was really tough. We are absolutely going to talk about that in a minute. But first, I just want to get a sense of like, how'd you feel when you walked into that call? Were you nervous? Were you excited? Were you totally jacked up? Were you upset? Were you sad? What's going on? Anybody? Any feelings? Initially, in the early stages of a lot of trainings, people will just be like, I don't know, I didn't really feel much. But as we keep encouraging them to do that, creating that reflective practitioner, that person who's going to start thinking about it. They know I'm going to ask now, so they're at least thinking about it. They may still not have a lot of feelings about it, and that's okay too, but keeping exploring that. Because then, even if in that debriefing they don't talk to me about it, but they go off with their buddy who's also a firefighter or paramedic or cop or whatever, maybe there's a chance they're going to start having those conversations, and we're going to start getting people help that they need, or helping people process through stuff so they can have longer careers, so that they can get to retirement, so that they can live past retirement and keep having those super fruitful lives, right? In and out of the service. When we're faced with reactions, I don't know about all of you, I know I am not specifically trained as a psychiatrist or a psychologist. There are going to be things that come out that I'm not prepared for. In a lot of the medical schools I've worked for, when we know we're putting together a scenario that's going to be particularly difficult, end-of-life conversations, breaking bad news, some of that kind of stuff, we often will pull in that specialized help to have it ready and on site for immediately following that thing. Because we don't know, like, you know, all right, today your scenario, you're going to walk in and you have to deliver this diagnosis of a glioblastoma to this person. It's a terminal diagnosis, whatever. We don't know that that student's grandmother just died of that, or, you know, whatever it happens to be. We don't know what's going to hit hard. So we want to have those resources there. That doesn't happen a lot, right? Or we know when we're going to create those scenarios that are really going to push those buttons. If we're not pushing those buttons, though, there's some pretty common techniques that we can use to help diffuse some of that emotional response. And we might put something in the back of our mind that, hey, I probably need to check in with this person and help them get to some other resources later. But in the moment, the things we can help with are things like normalization. Oh my gosh, yeah, I remember the first time I went on that call, I had exactly the same response. You know, what I did was X, Y, or Z. Or, yeah, PEDS calls are super stressful because we don't go on a lot of PEDS calls. So that's always going to amp me up for sure, whatever it happens to be. But creating that thing where you're creating that relationship to say, you're not alone in this. It's a normal and totally appropriate response. Let's figure out how we process it. Validation. Yeah, absolutely. That sounds tough. I can imagine that would be really tough. You did a great job moving past that. How are you feeling now? How is that? Where are you with that right now? Generalization, kind of taking it bigger and saying, oh yeah, you know, every time I hear the tones go off, that just immediately puts me here. And then when I get the call information, it takes me to this place or this place. Naming the dynamic, particularly when it's interpersonal, if somebody is feeling really upset about something, we tend to get a lot more into teamwork and communication training in a lot of the sim that we do. And so a lot of times we'll start to see interpersonal or interprofessional dynamics come out. And that's where we'll have to be like, oh, okay, that's really interesting. You were super upset because you felt like you were ignored that entire time. Maybe. Validation. Yeah, I kind of noticed that too. I think we should talk about that a little bit. Or, let's talk about that. So you felt like you were ignored. You were the only RT in the room. You were the CNA, but you were the first person there. You were taking care of that patient. And then the doctors and nurses and everybody came in. What was everybody else thinking when that happened? You know, when you blew into that room, you walked right past that CNA. What's going on, right? What's that dynamic like? Paraphrasing, so responding back to them and saying, so what I'm hearing you say is whatever it happens to be. Broadening, taking this little thing and saying, oh, do you generally feel like that? Is that a normal thing? Do you feel like that all the time? Is that a regular bit? And then previewing, helping them kind of move to that next stage. So that's really interesting. You know, what I'd like to do is I'd like to take that topic that we just talked about. So you're really upset because nobody is asking you questions when they walk in the room and it's your patient. What I'd like to do is I'd like to talk a little bit about what communication looks like in that initial response to that code, or when you show up on that scene and XYZ is happening, right? So telling them what you want to do, but almost asking them, leaving it up to them, making it that learner-centered. They are the focus. They get to drive the agenda. But doing those things can help diffuse things, can help name what's going on, identify it, move past it a little bit, even if it's something you need to put a pin in and come back to. Make sense? In the description phase, so moving on, we've gotten through our reactions, everybody's had a chance to kind of talk through what they're feeling and thinking and all that. What just happened? What did you guys just go through? Now, a lot of folks, their instinct, particularly when you're new to SIM or new to education, is you want to tell them what they just went through. But you know, like you had the scenario document in front of you, you designed the training, you know all that stuff. What you want to know is, what do they think they just went through? Because this is going to give you a lot of really interesting information. Number one, it's going to help you understand what their situational awareness was. Were they aware of all of the different moving pieces that you had put into play on that? Were they seeing the same scenario you were? Did they think it was just an anxious 22-year-old, or were they also thinking cardiac event, cocaine, who knows what else, right? And then giving them the chance to talk through it, what we found particularly with second-year medical students a lot, which what a fascinating group of people to work with, because they are typically very intelligent. They often are coming with not a lot of previous experience in healthcare and in patient care. They are incredibly creative. The number of times they would come up with a solution that I would be like, that is not a thing I would have thought of. It was maybe a good solution, maybe a terrible solution, could go either way. Or they would just like appear out of nowhere with some piece of information that I would have never guessed. Really interesting. But in the description phase, what we would do routinely is we would say, hey, I am your attending physician. Why don't you give me a patient handoff for the patient you just saw? Walk me through the scenario you just had and give me the highlights. Yeah?
So I do that, right? And
Yeah.
Like start me at the top of the call, just kind of walk me through.
Yep.
Like, and a lot of them jump right to patient care. I'm like, no,
Sure.
no, like what was the tone? Like,
Yeah.
what am I thinking? But like, so as they go through, I think I talk too much frequently, and as they go through, I interject and I'll be like, oh, well, I want to pause there because that's not, I didn't observe that, or I think you're jumping ahead, and I try
Sure.
to walk them back, but then it kind of gets like muddled. So do you let them go through the whole like report or the whole case or whatever, and then you like walk it back, or as you go?
It depends. So you will find that most of my responses to most things will be, it depends. So in the context of second year medical students, or in the context of paramedics, let's say, if they are new, they are novice learners, they are novice providers, they are novice whatever, I may interrupt them. I don't want them to build that habit of, this is the thing. And either I'll interrupt them, or sometimes even with this, I might say, just tell me about this part. And then, they'll start to come over here. Hey, hold on, let's finish this part first, and then, yeah, we're going to go to that. Build that, train them to do that, right? So in the debriefing, we have an opportunity to train a lot of the things that we have historically never trained. Becoming a reflective practitioner, writing notes, being able to give a verbal handoff, doing reports on the radio, whatever it happens to be. And it just depends on what skill I want to build in that moment. If, on the other hand, they've been doing it for a long time, we've got an established method of doing this thing and all that stuff, I might let them run. But typically in the pre-debrief, I'll let my learners know, hey, I'm gonna be taking notes and things while you guys are talking. It's not because I'm like, oh, hell no, you did, right? I'm not reporting that out, but it's, you said something that was interesting to me that I want to follow up on. So in that instance, if I know this is the method we're using, and like here there was a thing, I'm gonna let them keep going, but then I might come back to it afterwards and say, hey, I noticed that you got the tones, this was the call information, and you said these things here. Did you know those things here, or is that something you inferred? And why, what made you infer that? What were you thinking? What was that? Oh no, actually, I didn't think that then, but now that I saw this, I thought that. Okay, that's interesting. That's a different thing. The other thing that often comes up is, particularly, again, second year medical students, we would routinely do groups of 5. My personal opinion, you take 5 second year medical students and squish them together, and you have about all of the information that you really were hoping one of them would have. It's a huge volume of information. Like, their education system is totally different than the paramedic approach. But you get 5 of them, and pretty consistently you're going to have everything you need if they can work together as a team. we'd have them do their description phase, and you'd have one person that would be like, what? We were treating a patient with pneumonia? The whole time I thought it was, whatever. And it was common enough that it really underscored to me, one, it helps then understand, like, oh, we're going to stop for a second. We're going to talk about, like, why did you think that? Like, you were the scribe. My goodness, how did you not know what everybody else was thinking? Let's close that gap. And then also, it gave us, we did a lot of stuff. Are you all familiar with Team Steps? Have you guys heard that? It's a teamwork and communication system that the government and the Department of Defense kind of put together, particularly for healthcare systems and things like that. A lot of pluses and minuses to it, but we introduced it as part of our second year medical curriculum. And so in that, then we could talk about, like, oh, these are tools, like, okay, so you were, way over here, we've identified where that gap came from. Like, this was the moment that you did not have the same information as everybody else. This is how we create a shared mental model surrounding that. This is an opportunity to do that. So let's practice that right now. Like, all right, so in this moment, you ordered that thing, you did that thing, you didn't tell them you did that thing, like, here we go. And so it's just uncovering those gaps, but this is a place where you can start finding some of those gaps. Any other questions about the description phase? A lot of times in EMS, we'd stick to pretty straightforward, either paramedic to nurse or radio reports, because it's just a pretty convenient way, and it's a skill that we don't train a lot. The first time I gave a radio report was in the back of an ambulance during my ride time. Well, that's super stressful because I just did my first call. Okay, that's a big deal, right? And I'm sitting in front of two people that I don't want to think I'm a total idiot, and they're just like, here's the radio, and I'm like, but I read it in the book. I certainly didn't sit at home in the mirror and practice it. Maybe I should have, but this is an opportunity then to practice that stuff. And then we get to the analysis phase. So when we talk about the analysis phase, that really is kind of the debriefing. In Pearls, we break it out as this because this is where we have the three discrete methods of debriefing, the different approaches to different problems, depending on what your objective was, what your level of learner is, their ability to reflect, the amount of time you have. These are all things that you're going to then consider when you're trying to figure it out. And the three pathways that we have are learner self-assessment, more commonly referred to as plus delta. What went well? What would you do differently next time? And we do kind of steer towards that, what would you do differently next time, not what went poorly, because a lot of times we'll see there was a particularly good performance that we want them to carry forward. So it's not just, hey, next time, don't do this, don't do that, don't do this. It might be, oh, you know what? I didn't even think about it, but when you did X, Y, and Z, man, with every patient, I want to ask the question that way. Or when we approached this house and we called out X, Y, and Z, like, that was really good, and I had never done that before. I'm definitely going to do that next time. Or I'm going to do it faster next time, or I'm going to whatever. Focused facilitation, that's that advocacy and inquiry method. And so that's where there's maybe a particularly sticky subject, there's something that we really want to dig into a little bit more. And sometimes you'll see that plus delta and focused facilitation will start to work together. So in plus delta, I might say, what went well? And you would say, oh, this went well. And then I might say, oh, that's really interesting. Either I don't totally agree, I don't think that went super well, or I do agree. And then I'll follow the advocacy and inquiry pathway within that. And then provide information, or what used to be called directive feedback. And that's where there's a right answer, right? We know the right answer. We know the people have been trained to that right answer. So you come in and you're running a code scenario, and they walk in and they just start slapping the patient on the chest like this. And you can be like, all right, look, like, I noticed when you came in, you were doing kind of lackluster CPR. Let's talk a little bit about what high quality CPR is. We know that it's a compression depth of this, it is a rate of this, we want full recoil at the top, whatever it is, but we know there's an answer, and that helps us avoid what we call guess what I'm thinking questions. So when I first started in debriefing, there was a lot of stuff where we might say, all right, everybody, so, when you came in, we saw this patient who was laying on the ground with no arms and no legs and no pelvis, and you decided to start CPR, that was really clear. Who wants to tell me about high quality CPR? And then you'd just sit there and they would stare at you. Or they would start then trying to think, like, what element of the CPR was bad? Maybe it wasn't even bad. Maybe it was great CPR. And I just want to reinforce that you guys did great CPR. Here's the thing. So rather than them having to guess what I was thinking and why I asked that question, just tell them the answer, that's fine. And that helps us avoid teaching as well, right? So we don't want the debriefing just to become another lecture, another opportunity for us to tell everybody what's up. But in these moments, we just want to tell them what's up. So just get in, tell them, get back out. When we look at feedback and teaching, so directive feedback, learner self-assessment, focused facilitation, each of those takes different amounts of time. So focused feedback, straight in, right? Get in, tell them, get back out. Learner self-assessment, it takes a little more time because you're trying to get the learners to kind of talk through, like, what went well, what would you do differently? And they're going to take a little time to think about that. Some of them aren't going to want to speak up. It's going to take a little more time. And then focused facilitation, it does take quite a bit longer because you form these bigger questions and it is more about the conversation that you have. Super valuable, but if your time's limited, it just may not be the right choice. These tend to focus on different domains of learning as well. So focused feedback is going to be those algorithmic things, the things where there's a right answer and a wrong answer. We know this is how we perform this thing. I don't need to know why you didn't perform it the right way because it's literally a technical skill. This is right, this is wrong. The end. Plus delta, you can kind of get all over the place. You can get into any of those things. And then advocacy and inquiry tends to be more towards that behavioral or reasoning. I want to understand why you did the thing you did. I want to dig into that a little bit more. With feedback and teaching, we know their rationale. So we don't need to necessarily explore that. We just need to correct the specific action. Learner self-assessment, we don't know, maybe, maybe not. It kind of depends on what comes up. And then in focused facilitation, we don't know. We don't know what their logic was, and so we want to have that opportunity to explore that. And then with the experience, feedback and teaching is super easy to do for people who don't have a lot of experience, right? You're teaching your first CPR course, it's their first CPR course. They don't know the answer. If they didn't do high quality CPR, it's not because they forgot or they made a decision based on their lunch choice or something like that. It's typically, they're just new. They just need that directive feedback. Whereas with learner self-assessment and focused facilitation, it does require a little bit more experience and knowledge of the learner because they've got to be able to reflect. Now, I have found that with most adult learners, they have an ability to reflect that is more than I would have expected. Sometimes they can get where I want them to go, sometimes they can't, so we kind of play that by ear. But definitely as you get people who are more experienced in the field, those are going to be spaces you spend a little more time. When we get into the learner self-assessment, so that plus delta, the real advantages of plus delta are we're able to identify positive performances as well as negative performances. So areas for improvement, positive, either way, we're going to get to the bottom of it. And when we ask the learner to do that for us, the advantage is we find out what they think about it. So sometimes they're right on. Typically we find that even with pretty novice learners, about 80% of the time, they land on the same pluses and deltas that we would. Sometimes though, we find out that they'll be like, yeah, this was awesome. Like we did such a good job. And you'll be like, oh my, I do not totally agree. That's going to give us some things to talk about. It also gives us the opportunity to reinforce positive behavior. So not just this was good, but like you guys did this really well, but I don't know that you understand that for the level of learner and for my expectations for where you should be, how much better that was. Let's do that every single time. That really was remarkable. Let's carry that forward. And identifying discordant assessment of performance, which is just fancy for they thought one thing, but they were wrong. Or they thought one thing and we don't totally understand why they thought that was particularly good. So let's talk about it, because maybe it's not that they did poorly, it's that their criteria for high performance was just very different than yours, right? What does success look like? And then like everything else, it lets us close those performance gaps, whether it is taking a negative performance and carrying it forward or taking a positive performance and bringing everyone up to that level. But having somebody be able to explain how they arrived at that particularly high quality performance just gives the opportunity for all the learners to get there. Some of the downsides to learner self-assessment. So because it's learner-centered and because we typically then put it to the learners first, there are some downsides. Particularly if somebody is relatively novice, their performance assessments may not be super accurate. Now, my experience has been most people think more poorly of themselves than they think very highly of themselves. So they'll think something went really badly, and I'll be like, look, this was the second time you've ever run this. You've never seen a real patient. This was your third plastic patient. You did a really remarkable job. Yes, these are the things we're going to do differently as we move forward, but still, that was still pretty high quality. On the flip side, when you have someone who is particularly new, they routinely will overestimate their skill. And this is an opportunity to talk about that. And if they have that inaccurate assessment, we're less likely to see the behavior change that we're trying to go for. So we may have to dig in a little bit more with them. That said, self-assessment promotes real change, right? So you're more likely, if you or a near peer, somebody who you consider to be kind of an equivalent to you, if you get to identifying the gap of yourself, you are more likely to take that, internalize it, carry it forward, and actually make that meaningful change. It's like when you go to the doctor and the doctor's like, you need to stop smoking. And they don't say, hey, are you interested in stopping smoking? If you're interested in stopping smoking, you're probably more likely to do it than if they just tell you to. That objective feedback helps that informed self-assessment. So when we're talking about this, the way we try and look at any performance, it is about observed behavior. So it's not, gosh, you looked like you didn't know what you were doing right there. You might say, hey, I noticed when you came in, you paused for a really long time. Tell me about that. What was going on? What were you thinking about? It's different, but it's objective. You are looking at something that then somebody else might also see and be able to report on. And then that accurate assessment then creates greater behavior change. So as we dig in, as we get to the actual root of the problem, whether it was that emotional response, it was a lack of information, it was misinterpreting something that they saw, whatever it happened to be, we're going to create a bigger change because we're addressing the specific gap rather than the general gap. Does that make sense? For directive feedback, same thing. We're using that observation. So I noticed when you came in the room, you just started slapping the patient on the chest. That is not typically what we consider high quality CPR. These are the elements of high quality CPR. Providing that suggestion for change, and then giving the rationale for change. So this is why we do it. We know high quality CPR is one of the only things that will work in cardiac arrest. So this is the change that we're looking for. This is what high quality CPR looks like. Let's make sure we do that next time. All right, everybody, let's go back in. When you teach those AHA classes, particularly the old practice while watching ones, that's what we did all the time. It was constant directive feedback. They're doing the CPR, they're watching the videos, and you're saying, all right, I need you to go to deeper. All right, we're going to practice again. We'll keep doing that, right? Same idea. Advocacy and inquiry gets weird. I really like it. It takes a lot of practice. It is easy to inadvertently get kind of weirdly judgmental and jump all over it. But in advocacy and inquiry, what you're doing is you're saying, this is what I saw, this is what I think about what I saw, and then you're inviting them to conversation. So this is where it becomes that professional recognition. So keeping that identity intact. Instead of saying, you did this wrong, we need to do this differently, or why don't you tell me what you did right and wrong, and then we'll go from there. It's saying, when you walked into that room, I noticed that the first thing you did was push right past that CNA. I'm concerned about that because that CNA has been with that patient all day. That CNA probably has a lot of really valuable information for you. And so it might be worth having a conversation or getting something from them before you immediately jump into patient care. What do you think about that? And they might say, every CNA I've ever worked with doesn't do that. Okay, well, that's one problem we're going to talk about. Or they might say, oh my gosh, I didn't even notice the CNA when I walked in. Or often what happens, no, I totally asked them. Nope, you did not. We watched this. It was an observable behavior, right? So it's providing that question and kind of getting to it. It's a lot more exploration. It's a lot more conversation and digging in. And then application and summary. So we do this at the end of each topic. So we talked about previewing earlier. So if we go through the slappy CPR, at the end of that, we might say, hey, so we just talked a little bit about high quality CPR. We kind of landed on these as the elements of high quality CPR. Does anybody have anything else they want to add to that before we move on to another topic? No? Great. Okay, so moving on, you had mentioned that a plus was this. I'd really like to talk about that a little bit more. And then we do that, and we summarize each thing. And then at the end, we do the big summary, right? Awesome, thank you everybody so much. what's one take home everybody has from today? What's something you're going to do with your next patient that you learned today? And just that big take home, that big summary. That is pearls in a nutshell. Questions. I know it was like drinking from a fire hose. Not that I've drunk from a fire hose in a very long time, but.
I'm going to be that person who asks the two large, obnoxious questions.
Interesting.
Shamelessly.
They don't seem surprised.
No,
No.
they're not. So you may get to it. At this point, you've pointed out successfully huge gaps in knowledge that I have as an educator, but you've also identified and conveyed the value. What could I, as somebody who's like, oh, yes, what are my next steps?
Yeah, that's a great question. So the first thing that I would do is, on that Dropbox link that you guys will get sent, there is a Pearls, I think it's just called the Pearls Cognitive Aid. And it's two-sided, it's an 8.5 by 11 sheet of paper. And it has, first, just all the steps of Pearls: reactions, description, analysis, blah, blah, blah. On the back side, it's got, within the analysis phase, here's some suggested questions to start off those things. My personal opinion, get started with reactions and description right away. And think about how you want to do it, right? How do you want to have that conversation with people? How do you want them to provide their description of the experience they just had? And then in analysis, I always start with plus delta. It is just my go-to every single time. I may never make it out of plus delta. I might just use that. It is relatively simple to teach people how to use, right? Even your learners, they'll be able to interact with it pretty easily. It's pretty straightforward. It's going to cover a lot of the same material you would cover with any other method, and it just gets you started. So that, and then practicing that summary of each thing.
And then I apologize.
No, don't at all.
So I also teach initial EMS programs. I have maybe about 100 students a year that I put through. And you touched on something I think that was really important. Kind of other healthcare disciplines are using this, but something I've identified in EMS education is what you call psychological harm. I've intuitively been calling empathy. So like that already exists, but I think there's great potential for incorporating that in these initial programs, because I think a lot of what I try to do is tell them like, hey, I'm going to teach you medical knowledge that's 2023 accurate. What I really need to do is give you tools and frameworks to learn on your own and develop yourself. And how can I add that as a tool that I give them?
Yeah.
Even though we're not, maybe at the end of the program, you're including this kind of simulation, but how, because they still have to get that foundational knowledge, how can you incorporate that from the get-go?
Right. So I think what you're asking is, how do you incorporate some of these softer skills and some of these adjacent skills into that early learning where it is just like, here's some more information and here's a little more information, right? So I call that Mr. Miyagi stuff, right? And that's where I'll use previewing in almost all education that I do. So for instance, if I know in sim we're going to struggle, like I just get to know this group and I think we're going to struggle a little bit with the reactions phase with these folks. They are not super touchy-feely. Or I'm noticing that there's the station house joking around that can often be pretty psychologically unsafe because it's making fun of each other. And it's all in fun until somebody is in a situation where they are feeling like they just messed up really badly or whatever, right? And so in that instance, I'll preview all that stuff super early. And I'll say, hey, you know what? Every once in a while, I'm just going to ask you guys how you're feeling. And I'm just going to check in because EMS is difficult. Fire is difficult. I know that I want you to be able to reflect on these things as you move forward, and here is why. I think that it is valuable for your long-term career, it is valuable for your long-term mental health, and I want us to be able to talk about it pretty freely, so I'm going to ask you about it. And you just start baking it into everything. And the same thing with empathy, and even just the other elements of psychological safety. Like I said before, you don't just plant psychological safety, you build it over time, and it's about building rapport, and it's about creating that relationship with all the learners. You do that through the other things. So through some of those techniques like validation, generalization, and all of that, when someone is struggling and they don't do well on this test, or they don't, like their knowledge isn't quite where it's supposed to be, that's a totally appropriate time to say, you know what, lots of people struggle with neurology. Like, that's a super tough unit. That guy didn't because he never does. So like, I didn't because I don't. But man, cardiology just absolutely crushed me. Everybody's gonna find their thing that's tough. So let's work on getting you there. Our goal is just to get you from where you are, wherever that is, to here. And you just keep creating those things and just kind of baking it into stuff. Does that sort of answer your question?
Yeah.
Indirectly, at least?
It helps.
But yeah, I spend a lot of time with the Mr. Miyagi style of I'm teaching you a thing that you wouldn't necessarily normally do. Medical students, it's all about the emotional stuff, and it's all about that description. We're going through this description phase. You feel like you're just telling me so that I know that you know. No, that's not it at all. I want you to practice this thing. Here's this algorithm that we use. Here's this tool that we use for this report or that report.
This is going to be weird, but it's nice to have names for things that I'm already doing.
Sure.
Because then you go, oh, that's what's happening.
Yeah.
Oh, okay, now I can further look into it.
Yeah, and then it helps you connect to what people far smarter than I are then talking about doing, things like that. So I got the sign that we're kind of closing in on time. For some reason, I thought we had more time than we have. So I have more stuff to talk about, but we'll save that for another day.
We do have plenty of time. My watch.
Oh, okay, perfect. I thought, ooh, 15 minutes. I thought I had 45 more minutes. My God. Lucky you guys, 45 more minutes. Just kidding. Yeah, now half an hour. Yeah. It's the 15-minute sign was 15 minutes ago. So just some quick strategies for effective debriefing. The biggest thing to me, yeah, guys, run for it if you have to pee, if you have to do whatever, if you just don't like my shirt. I won't take it personally. One of the biggest things that we struggle with, particularly when we're first learning how to debrief, is being learner-centered. And I keep saying that word. When we talk about learner-centeredness, fundamentally, one is you're just meeting the learners where they are, right? And so to that end, in the debriefing, giving them that plus delta lets them set that initial agenda. What are the things they want to talk about? And that's going to help because, one, they're going to stay engaged more, they're going to talk about things. And typically, if we're seeing that they're hitting at least 80% of the same things we are, that's awesome. Secondarily, though, we also know that they're going to miss some stuff. And sometimes that stuff's going to be big. Or they're going to want to talk about how great this thing went or whatever, and you're going to be like, you almost died. We still have to bring them back to that. So learner-centered doesn't mean that you just sit on your hands and you don't say anything. There may be times when you use that previewing to switch. So, hey, yep, that's great. Like, I'm super glad we got to talk about the communication that you guys had and how valuable that was and things. One of the things I really want to talk about, though, is you gave 10 milligrams of Versed to that patient when 1 was what you meant to do. Let's talk about that a little bit. And then we can have that conversation, right? Whatever it happens to be. But we still want the learner to kind of set that, and we want them to help negotiate that order of topics. So if they want to talk about the negative stuff first, or the things they felt like they really messed up, that's totally fine. Most of us have a little bit of a negativity bias, and we start steering that way. But we do still want to offer them also the things they did well, presuming there were some. Typically, you can find at least one. We also want to uncover the learner frame. So we talked about that, exploring the depths and their decision-making paradigm and all that. We call those learner frames, which is really just what was the thing they were looking through when they looked at this problem and made a decision. If we consider that they all had some logic that they applied, that they are intelligent, well-trained, well-educated people who want to be good at their job, then there was something about this frame that if the performance was not what we expected, something about that frame was wrong, but we need to talk about that so that we can swap out that frame for something else. And we want to encourage the group in that discussion. There's lots of techniques that go with that. That is not for today. But ways to encourage the group to learn together, that near-peer learning becomes really valuable because as they learn as a group, they're more likely to really carry that forward. And then guide on the side, which we kind of touched on early. So there's sage on the stage, guide on the side. Sage on the stage is, I'm going to tell you what you did wrong and what you did right, and then you're going to leave and feel good about it. Guide on the side is why don't you guys talk to me a little bit about what your experience was like, tell me what was good, what you would do differently next time. And I might offer some input there, here and there, because yes, maybe I am the subject matter expert. I am facilitating this conversation. If I'm facilitating the conversation and I'm not the subject matter expert, I might turn people to each other. So, oh, I didn't know what to do and da-da-da. Oh, that's really interesting. What does the rest of the group think about that? Like, how would you have approached that problem? Turning it to them, it takes some of that load off of you, puts it back to those learners. And then they can start closing their own performance gaps. The learners determining the duration of the discussion, we don't need to beat a dead horse. In a lot of the sim literature, they say that the debrief should be 2 to 3 times as long as the scenario was. That came from a manual. That is not actually a rule. That came from a manual that somebody wrote when we had no guidelines at all, like 25 years ago. Just from like a logistics and planning standpoint. They're like, oh, this sounds good, we'll just put that in there. And somehow it just sort of like rose up through the thing to everyone being like, it must be 2 to 3 times as long. Talk until you don't have anything to talk about. Talk until you run out of time. Whatever it happens to be is great. Personally, and I know this will shock all of you, I generally find that we can fill whatever time we have. Use that time productively. But when people come to me and they say, yeah, there really wasn't anything to talk about, I think then you were not watching their performance. Because if our goal is just to move the needle, even if they nailed the whole thing, awesome. Let's talk about how to make it even better next time, right? So use that time. It's super valuable time. And then have the learners identify the take-home messages. So while I might summarize the individual thing and say, all right, so we just finished talking about high-quality CPR. We agreed that these are the elements of high-quality CPR. At the end, I'm not going to say, and what you're going to take home from this is this, and what you're going to take home from is this. Ask the learners to do that. It just keeps them and helps them kind of really solidify that point, and it shares between people. Because if I'm sitting here thinking, oh, I don't know what I really took from that, but all of a sudden, this guy that I've been taking classes with forever is like, oh man, it really blew my mind that this happened. Then all of a sudden, I'm like, oh, if the guy that I think has it all locked down, like he took something from this, like it just changes that relationship and helps them carry it forward. Now, like I said, drinking from the fire hose. How many of you guys have heard of the concept of cognitive load? That tracks. It is a very squishy topic. It is one that is really difficult to objectively measure, but the idea really just is we got to think about a lot of stuff while we're trying to do all of these things. When we talk about cognitive load in training, when we start training, we start on like specific skills, we build up these little pieces, and then we keep adding to it to get to a point where then we are performing in an environment that is similar to the environment we would actually be working in, right? We increase the cognitive load over time. Because what we find is when people just jump straight into the deep end, they're just so overwhelmed that they're not taking as much with them. This is part of why we use the reactions phase, is because we know that if somebody is still in a heightened emotional state, they are unlikely to take as much from that educational conversation that we have than if we've given them a chance to kind of ratchet down a little bit, right? It's another benefit of that reactions phase. For this, though, I just dumped a couple of weeks of information about debriefing on you all. And so it's a lot. And so I appreciate your question about, like, what do I do next? There are ways to reduce that cognitive load. And when we talk about cognitive load, there's 3 pieces to cognitive load. There's germane load, which is just the load that exists within the task you want to do, right? It's just, it takes brain power to do stuff, the end. There's intrinsic load, which is the stuff that you've got in you. So the things that you're carrying with you. So I got to keep myself on lockdown because right now I'm super mad because these students I've been working with for 2.5 years, who I really expected to do better, just really messed up that whole simulation, and I'm kind of cranky about it, but I got to lock that down, so that's going to take a little bit of load. I have to figure out how to ask my questions. That's going to take a little bit of cognitive load. I need to remember everything that just happened in that simulation and the things I wanted to talk about. That's going to take some load. I need to prioritize the topics, both let them prioritize some, but not lose track of the ones that I've got. I'm going to ensure I'm doing effective teaching because, right, I just got this whole list of ways to do things, so now I need to make sure that I'm checking these boxes and I'm doing. It's a ton of stuff, right? Extrinsically, then, you've got all the stuff that isn't inside of you but is still weighing on you. So how realistic was the scenario? What happens when the learners go clear over here and I need to bring them back? The physical space isn't set up right. This is kind of weird and everybody's spread out and it's tough to manage the classroom. I've got this one learner that's just a total jerk and I can't get them to stop talking, or they won't talk, or they whatever. I'm doing a code debriefing, so now I also have to manage this other person that I'm helping. Right? It's a ton of stuff. So there's lots of ways to manage those things. Now, with the germane load, so the things that are going to happen, we're going to have people that they're on track, they're venting, they have questions, feedback from learners, feedback from the peer coach, debriefing assessment tools. That's the stuff we know we have to do because it's just part of the task. So we're going to keep these things in mind. This is where Pearls really shines because it manages a lot of those things. It breaks them into bites, and it then lets you work through each section, and you can say, all right, for this section, I only have to worry about these 3 things. For this section, I need to worry about these 3 things. And then, adding on to that, when you are engaging in learner-centered debriefing, you're shifting so much of this off to that group of learners that you're taking a lot of that load off of yourself, which is super good. We'll skip past that. So when we talk about intrinsic load management, the things that make it worse, quantity of information. So when we're designing our training exercises, in sim, we typically say we want 3 to 5 objectives, right? Now, I know where I am currently, people are like, here's my objectives, and there's like 30. Sometimes those objectives are really performance measures, so it's like, I want them to intubate, I want them to whatever, right? Okay, that's maybe not an objective, that's just like a checkbox. The reason we go with 3 to 5 is that's just managing the amount of things we want to keep track of. It doesn't mean there are other things going on in that scenario, but these 3 to 5 things are the primary focus. So if this thing goes wrong, unless it's really major or really like a patient safety issue or something like that, I may just let that go because this was the focus of the simulation, of the training itself. The emotional state of the learners, right? So if they're super amped up, that's going to be a thing that's going to be really difficult to manage. It's hard to corral that energy, giving them that opportunity to get it out, to talk about it a little bit, even if it is just venting. It is just straight up like, yeah, that was super frustrating. I didn't even know what to do. Yeah, I totally get it. Those calls are really frustrating, so let's talk about it a little bit, right? Just bring them down that peg. Not having enough time. So I don't know if you guys deal with this, but the training time that you're allocated is typically less than a third of the training time you probably really need to do a lot of things you want to do, right? So for us, we're trying to get doctors, nurses, RTs, paramedics, everybody to come down to this training center to do the stuff. When we say, all right, the thing you want to do is going to take 2.5 hours, they're like, well, we've got 12 minutes. So like, what can we do in 12 minutes? Well, not a whole lot really, but not having enough time to do that. So managing those expectations and compressing those things. The expertise of the individual, right? Being able to manage that. So when we look at all of these things, the way we can offset those, if there's too much information, people are talking about a lot of stuff, there's too many things you want to talk about, take notes. Let them know you're going to take notes. Have them take notes. Put a whiteboard up and say, all right, I'm going to have you just jot down things as they come up as we do this plus delta. Using the pre-briefing to build psychological safety, giving the reactions phase, all that helps offset that emotional state of the learners. If you don't have enough time, shorten the scenario. Do smaller doses more frequently. So like with a lot of our docs, they have 1 hour a week for their clinic time, or not clinic time, their fellowship time. In that fellowship time, they're getting lectures, they're doing all this stuff. They have a bunch of stuff they have to do. Rather than trying to get them to come down quarterly for a 3-hour training, we take 15 minutes of that hour once a month. It's not the same amount of stuff, but all right, let's talk about how we can be efficient and we can still touch on all those things. Divide it up. If you don't have the clinical expertise or the specific expertise for the simulation scenario that's going on or the training you want to do, have somebody come in. Invite somebody to come along as a co-debriefer. Let them know, like, hey, this is how it's going to work. I don't expect you to be able to manage all of this stuff. I'm going to do the reactions phase and the description and all this stuff. But I might flip some things to you if certain questions come up, or if there's something you want to talk about, hey, just like give me the high sign, let me know, and I'll be like, hey, Tom, what do you have to offer? Go ahead, speak up. And then debriefing expertise. We're still new to this, so have a script. If we get too rigid in that script, it gets weird, but you'll know when it gets weird, when it's too rigid, because you'll start to feel it. You'll bump up against those edges. Start with that plus delta. Work through those questions on that debriefing form. Just use those questions. Hey, how'd that feel for everybody? Start there. Why don't you tell me about the experience you just went through? Tell me about that call. Just start there. you'll start to figure out how to be authentic to yourself, how to speak the way you need to be able to get out of your learners what's there. It takes experience, it takes practice like everything else. In my pre-briefs, that's one of the things I offer to every learner that I work with. Hey, just so you guys know, there's gonna be times in this where I'm gonna ask things a way that didn't come out the way I meant to. So if I ask to pause for a second and want to rephrase a question, just understand, in the same way that we're here to help you get better at your job, I'm trying to get better at mine. So if I ask you a question and it feels super judgy or it's really uncomfortable, say so, and like give me a chance to try and fix it too, and we'll work through that together. That also helps build the psychological safety, because now they're like, oh right, you're a human. You're trying to get better at the work that you do too? Cool, like we have an opportunity to do this. But having those scripts gives you something to lean back on. And in that Dropbox, there's a few other things that can kind of help build up those script elements. And then for extraneous loads, noise. I mean, that's always a problem. Sometimes we want that, right? During the scenario, we may want a lot of noise. We may want to build that up. But having that debriefing space be someplace where you can turn everything down, where you're isolated a little bit from the group. And that's true of real calls as well, right? Get away from the noise, the hustle and bustle of everything. If you're at the station house, find a place that is out of the main area where people are cleaning or doing whatever and all that, where you can actually have these conversations. Learner interruptions, that kind of depends on your management style. But with all these things, it's about setting expectations of respectful communication. So when I came in today, I was like, hey, look, get up and leave. Talk to me, ask questions when you have them, whatever it is. That's how I prefer to lead this. I don't mind those interruptions. If you start getting super crazy about it and you're throwing like knives and coats and I don't know, chairs or whatever at me, we might have to readjust our plan. But we're gonna do that together. Same thing with any interruptions, but managing those expectations and creating that plan. Use of video, all those sorts of things. There's lots of depth you can get into in different ways to debrief depending on how your sim space is set up. That's a whole other big conversation. So in terms of managing cognitive load, what are some of the things that you guys struggle with most when you're coming in to debrief, whether it's a call or a sim or an educational thing, or even just having a difficult conversation with a learner you're trying to help out?
I think kind of a limited resources from the educational side, and I'm sure I'm not alone in this, but many agencies, training, at least maybe not always the most well-funded, and it's like, okay, me as a training officer, me as the educator, kind of against the world. So it's like, oh, I as the educator role have very limited resources. Mm-hmm. How can I still be effective?
Yeah.
I don't know if anyone else experiences that, but.
Do you guys have all the money and stuff and things that you need? Because if you do, like, I'd like to come work for you if I could. That'd be great. We're super fortunate. I joke, but we're super fortunate. We have a lot of support where I am. Most of the places I've worked, we didn't. Some of that is about advocacy. So it's about being able to say, like, this is a thing that we know is a problem. This is how we fix it. This is what I need to fix it. Oh, you can't have that. Well, can I have this? Can I have this? And working with, particularly in education, working with the community that's out there, most people are having the same problems and everybody is trying to solve those problems. And we, particularly on the sim side, tend to do a poor job of sharing those solutions. So as an example, a dear friend of mine is the medical director and sim director of Texas Tech's sim program in El Paso. Before he became an emergency medicine physician, he was an engineer. He created a whole slew of task trainers, so just partial body models that you can practice one skill on, that each one costs less than $25 to build from Home Depot. I have a guy in my shop now who all he does is 3D print stuff for other people to be like, oh, you need Crike trainers? Great. Like, I'll print you 30 of them. It'll be $8.60. Do you guys have that? You know, whatever it is. So leaning on the community is one thing. The other thing I find that I end up having to do a lot of to take that pressure off is I don't really talk about sim or education anymore much at all. So like, I love debriefing. I wish I got to do more of it. Most of my time as the director of my program is just talking to people about efficiency and effectiveness and being like, hey, like, you want to do this thing and it's going to take this chunk of resources. But what I'm hearing you say is these are the things you want to accomplish. Let's do it with these resources. and then redistributing that stuff. So it becomes more of a management game, and it's switching the focus to be able to push that stuff off onto the other people who maybe have already solved those problems. That sort of answers that question. Maybe, maybe not.
I think it was more of like being alone, not alone, but like you're the one educator, now you have.
Sure. So for that then becomes a matter of training people to do the stuff that you can't always do. So an example for us, we don't have enough operations staff to be able to support our hospital system. So for DHMC, our main hospital, we've got 5 operations specialists, and they are pretty much full out 6 days a week, constantly. We also try and support the 4 other hospitals that we're kind of tasked with, plus the community group practices down this way. But we just don't have any staff to send them. So what we did was we said, look, like you want to do more sim, we can support you with equipment, we can support you with stuff, we can support some of these big things that are happening infrequently, but like the little small dose stuff, like you want to do CPR classes, an extension of that is codes. You want to do responding to medical emergencies, which is literally just like, how do we move people out of this thing? We'll provide you the curriculum and we'll train some of your people to do that lightweight stuff. That doesn't require an operations specialist. It requires, for instance, an administrative assistant who has been planning and teaching all of your BLS courses. They have enough knowledge and clinical expertise that they can do this thing. So finding those people that can carve out those tiny bits of time, and then you'll start to be able to make that. The other thing is I just hitch my wagon to whatever priorities I notice the organization has. So if DH makes the priority of we want to reduce obstetric emergencies and the impact of that coming from these rural areas, how can I better serve the programs that are working on that? And then I can say to the organization, in order to support that thing, these are the things that I need, because it's an organizational priority. I keep pointing at you for obvious reasons, but because it's an organizational priority, then resources come from different places and they can help me offset that because it's a priority. A lot of that. My undergraduate liberal arts degree comes in more handy than I ever would have imagined. Any other thoughts on cognitive load stuff, particularly as it relates to debriefing or things where you're feeling just like overrun other than all of it? Most of the time I've found that if I am pretty vulnerable and upfront about stuff, so when I first started debriefing, to say, like right out of the gates, look guys, I'm just learning how to do this. Like I have learned some new things that I am told will make debriefing better, will make the learning more sticky, will help you guys be better at your job, but I'm just learning how to do it. Do you guys mind if I try some of these things out? I might have to backtrack a little bit, right? Like I was talking about before. I might have to change that question. I might have to do whatever. Give me that little bit of space. I'll give you that little bit of space. If we're taking that basic assumption, that's going to take a lot of that pressure off, and it's going to give you a lot more room to work with. And then figure out your processes. If you need to take notes, if you need a whiteboard, if you need a whatever, those kinds of things. And then know that like, I've met 2 people in my life that I feel like are basically perfect at this process. I think it is just them as humans. I think regardless of whether all this stuff existed or not, that's just how they would function. Everybody else I've met, they have good days, they have bad days, and just ride it out. Any other questions about debriefing, about sim, about, I don't know, anything. I mean, I'll talk about whatever. We've got 10 more minutes. You guys were like, I just would like to go to the bathroom and maybe find some coffee. These are ways that it's easy to get in touch with me. Feel free to use any of them. I took all of these slides and I did also put those in the Dropbox, so all this information is in there. And then also, if you are doing sim stuff or you want to get into more debriefing things, this stuff also on the slides on the Dropbox, but feel free to go to any of these. The first 2, the Debriefing Academy and Debrief to Learn, that's that same group. They're out of Calgary, Canada, and they just are deeper into debriefing and how to do it well than anyone I've ever met. It is mostly focused on emergency medicine kind of broadly, but a lot of the stuff has been adapted to other things. Sim Geeks podcast is one of my favorites, particularly if you're looking at simulation operations, but they've been branching out into other things related to sim education and that sort of thing. Two good friends of mine, just a super fun podcast to listen to. There's tons of podcasts out there. And then SSH, SimGhosts, and Axel. Those are three of the biggest simulation organizations out there. Lots of resources come through them and are available through them, so those are good links to have. And then healthysimulation.com, it's kind of an amalgamator. It's a little bit like Las Vegas. Not that everything stays there, but that it's a ton of ads surrounding a little bit of content. But it is a good amalgamator, and it will connect you to lots of good content out in the world. So thank you guys so much for having me. I appreciate it. And if there's anything I can do to help you all out, let me know. The end.